On the Scene video coverage of AHA 2012 is supported by Pradaxa.
Welcome to On the Scene at AHA 2012. I'm joined by Dr. Tony DeMaria, editor of JACT, and Dr. Fred Bove, editor of Accel, to talk about today's late-breaking clinical trials. We have a very interesting one looking at platelet monitoring and whether that can be helpful in a strategy of adjusting antiplatelet therapy for prevention of cardiovascular events, the Arctic trial. This was done in about 2,000 patients and did platelet testing of both aspirin response and clopidogrel response with adjustment of the dose of aspirin in one case, or in the dose of clopidogrel, or switching to prasugrel to increase the intensity of antiplatelet therapy. And I think a very surprising but strong result at 1 year, there was no benefit of this strategy of testing and adjusting the intensity of antiplatelet therapy. I have to say, a bit of a surprise for me. Tony or Fred, what was your thought?
Well, gravitas was negative, so that I suppose we can't say it's a complete surprise since the major price, although trigger PCI did show benefit of prasugrel over clopidogrel, and so there was reason to think that if you applied this strategy to clopidogrel non-responders, it would work. I think an important caveat here is not ACS patients. These were elective PCI patients, so there remains some uncertainty about whether this strategy might do better in the acute patient.
Very, very good point. Certainly the large outcome trials like Triton, where you treat everybody with more intensive versus clopidogrel, there a benefit seen balanced by bleeding risk. Here, sort of finding the problem patient, adjusting just some of the patients means that the strategy really impacts only, say, a third or so. We don't have support for routine testing, I think, as of yet, and so I think we'll have to keep doing well-done strategy trials like this to try and say, could a new test get incorporated, change what we do, and does that new approach help? And so far, we haven't really found.
Yeah, two things I get from this. Number one is we still don't understand platelets well enough to figure out what's going on here, because there's so many nuances to platelet function that I think we still have to go back to the basic science to really understand why something like this doesn't have meaning, even though you think it should. So that would be number one. Number two is we're very sensitive nowadays to cost, and I think these kind of studies provide us some valuable support base to try to minimize costs. And if this doesn't work well in long-term decision making, then why spend the money on it? So I think there's some value in the studies, but as I said, the most important message I get is we don't know enough about platelets to figure out why these things don't come out the way they do.
And in fact, what's known is that the various tests of platelet function aren't always consistent. You get one result with one test, another with a different test. So it may be that there's a better test of platelet function somewhere if we understood a little bit more.
That's true. Yeah, I mean, we certainly have the big outcomes trials of more intensive in general. Not exactly sure how ticagrelor, prasugrel, but those have been seen to be better. But the sort of intermediate test and adjust had economic appeal, because you think, well, could you take cheap clopidogrel, adjust the dose, and just change some? But so far, we won't be able to be going down that strategy. Well, the next trial, I think, was also a surprise for probably everybody, the investigators included, it seemed. The TACT trial looked at chelation therapy. And so the buzz in the hallways is, quack medicine, but there is some science, I think, to chelation as an approach to try and reduce calcium, I suppose, and that's probably a part of coronary disease. An outcome trial sponsored by the NHLBI or NIH, and cut short on enrollment because they couldn't get people to sign up for the program, but they saw a benefit. at least the numbers said that. They kind of backpedaled a little bit in what they were saying. Do you want to describe a little bit?
Well, we've all scratched our heads about chelation therapy, and it's a popular therapy. It's going on whether we have data or not. There are people that go to these chelation sites and spend months getting once a week chelation. As you mentioned before, it's like dialysis in some ways. That you do this for a long time. And we've always thought that there wasn't enough data. I think there was some earlier studies that really didn't show much benefit from chelation. And this study basically tried to randomize patients into chelation or placebo, and using the EDTA standard that we use for chelating calcium. And lo and behold, there was a signal there. I thought it was interesting. I mean, it's in diabetics, it's in revascularization for the most part, but looks like, at least for the first look at this, there is some signal in value of chelation therapy in some subsets of patients. So I don't think we want to dismiss it out of hand. I think the investigators even made a clear point that more data and bigger trials need to be done, but there is a signal there.
Yeah. So it was a bit more than chelation. They had a 10-component cocktail, vitamins, minerals.
Perfect for Southern California, right?
So it was a cocktail, and it involved a commitment. You have to ask yourself, if you're willing to commit yourself to at least a minimum 3-hour infusion weekly for 30 weeks, the better part of a year, and then 10 additional. And as Fred pointed out, the bulk of the benefit seemed to be in the diabetics, and interestingly, they needed 5 composite endpoints, no single one of which was actually statistically significantly reduced, but in aggregate, all of them were primarily revascularization, that being the most. So, but nevertheless, when it's all said and done, now my recollection, George Weiss conducted an NIH-sponsored trial on chelation some years ago that was negative, I think a bit smaller. But this one did seem to have a signal.
Yeah, I mean, it's interesting, in doing trials, we often talk about the side benefit of trial of drug X is that you're seen regularly, followed up carefully. And so you wonder, with weekly, it's almost like cardiac rehab, obviously they're getting a different therapy, but could that component of close follow-up be part of what helped?
Of course, the placebo group also, they got normal saline infusions, so they were in there as well. But one thing, we often think of plaques as being more desirable if they're stabilized, if they're heavily fibrosed and calcified and whatnot. And one wonders about the wisdom of removing the calcium and softening up the plaque a little bit. It's almost counterintuitive.
Yeah. Well, I think the authors, and Tony Lamas led this, a terrific investigator, very carefully pointed out that this was a moderate-sized trial and needs to be looked at it with other data and potentially other studies. So we'll look forward to seeing that.
My first appointment for chelation is later on this afternoon.
There's probably plenty of clinics around here in LA to go rushing out and get that, or all kinds of other, Now, another thing I think that was presented were the economic results from the Seaport trial, and this looked at doing elective angioplasty at centers without on-site cardiac surgery, so tertiary care versus community hospitals and broad strokes. And there they really didn't see much of an economic advantage of the sort of peripheral PCI in the outside hospitals. I sort of thought that seemed to make some sense, but what were your thoughts?
Well, I think, number one, Seaport's been going on for 7 or 8 years now, and I think the original clinical outcome data was not surprising. The Europeans have been doing PCI in non-surgical hospitals for quite a long time, so I think we did Seaport, which was basically funded by by Medicare. It was not an NIH study alone. It was a Medicare-funded study to try to find out efficacy here. And that showed similar outcomes if you did PCI in a non-surgical hospital versus a surgical hospital. And I think a lot of that has to do with the technology that we've gone through with, with guide catheters in coronaries and with stents and everything else, making the procedure safer for usual operators. this analysis was the economic side of it, and basically it didn't show much difference. There were a couple of small differences in there. For the non-surgical hospitals, basically if they were a big medical center doing a lot of procedures, had a little lower cost that matched the surgical hospitals. The smaller hospitals with fewer numbers looked like they were a little bit higher, but none of that was significantly different. So overall, I think the message is it's not a big difference financially if you do a PCI in a non-surgical hospital than in a surgical hospital. And the other original clinical data from Seaport said if you're doing it right, you're going to get the same outcomes.
Well, it's certainly good, I think, as we move to health systems, should a system think about moving that, and that would not be a big cost savings, that one can really drive it off of clinical and obviously convenience potentially for patients. But I saw it as maybe some good news for the tertiary care centers that there still will be a reasonable flow of patients.
You know, if you pick the right patients, I think you can do reasonably well. Low-risk patients in a non-surgical hospital, but probably none of the three of us would have our own intervention in a hospital without surgery.
No, indeed.
Right. Well, the other thing I think you're seeing is a trend for healthcare systems to, number one, incorporate the cardiologist into their systems. And if they have a core hospital that's got surgery, and in several non-surgical hospitals, that same group of physicians is traveling among the hospitals. So in a sense, they're experienced core hospital operators that go out to these smaller hospitals. And I think that has a lot of benefit as well, because you're getting the experience in the smaller hospitals that you wouldn't get if it was a standalone practice with relatively low numbers.
Right. Okay, well that wraps it up for today's late-breaking clinical trials, and do stay tuned on the scene here as we cover each day's late-breaking trials at AHA 2012.